So today, the outline is to talk about a case first, and then how to diagnose a melanoma, how to manage a lesion which is suspicious for a melanoma, what to do when the histology report confirms a melanoma, and how to manage patients who've had a melanoma before. So the case is of a 45-year-old farmer who attends the practice for the first time. He wants a pigmented lesion on the right thigh looked at, given it has become darker and larger in the last few months. He's a bit of a vague historian. He says that he's had a melanoma excised from the left arm in Queensland and lots of other skin cancers. His parents may have had non-melanoma skin cancers before, and he's had more than 20 blistering sunburns in his life and has never been to a solarium. On full skin examination, his skin phototype 1, he has multiple actinic keratoses, and he has this irregular 7mm nevus on the right thigh. He has 150 nevi in total, 10 of which are dysplastic. He has actinic damage on his ears, scalp and lower lip, and there are no palpable lymph nodes. So the pigmented lesion looks like this, and I thought it looks a little abnormal, could be a melanoma. But the main questions from the case was, firstly, what's the information of the previous melanoma? We don't know anything about the depth, the stage, how it was excised, whether he had any lymph node surgery or systemic treatment. We don't even know what year it was cut out. And then we have to work out what are his risk factors for recurrence of this melanoma and what are his risk factors for developing a new melanoma. And that leads into, well, how often should we monitor this patient? And with regards to this lesion here, should I biopsy this or refer it to someone else? What's the correct method of biopsying this lesion? What do I do if it comes back as a melanoma? What do I do if it's not normal or not a melanoma but a dysplastic nevus? And what would happen if I left the lesion completely alone? Given that we're suspicious that it could be a melanoma, the best thing is to excise it, given that we know that if we left a melanoma, it would increase over time. So how do we actually diagnose melanomas? Well, the key thing is to take a good history and examination. Firstly, we look at all the risk factors, and then we see if the patient's concerned about a particular lesion. And in particular, we always ask a patient if there's a lesion that's changing. We know that with the patient risk factors, intermittent sun exposure is the key. So patients who've had chronic sun exposure over time are more likely to get squamous cell carcinomas and actinic keratoses. But we know that if they've had intermittent sunburns, especially during childhood, this increases the risk of melanomas. We also know that if they've been exposed to tanning beds, the UVA that they've been exposed to is a lot greater than the UVA that they get from the sun. It's important to also count the number of nevi that patients have on their skin. We know that if they have more than 100 nevi, this increases the risk of developing a melanoma by about 7 times. Also, if they have more than 5 abnormal looking moles, this increases the risk of developing a melanoma by about 6 times. And we look for the size of the lesion. So if something's greater than 5 millimeters, or if they have a giant, meaning greater than 20 centimeter nevus, this is associated with a melanoma. It's important to always ask about family history and personal history, especially if someone in their family or the patient themselves have had a melanoma at a young age, which is less than 40 years of age, or if they've had more than one melanoma. It's also important to look at the patient, see if they're red hair, fair skin, if they have light eyes, or whether they have a sun sensitivity. So these are the key questions I ask all patients. Firstly, how many sunburns have you had in your life? How many blistering sunburns have you had in your life? Have you ever been to a solarium? If yes, how many times? Have you had a melanoma before? Has anyone in your family had a melanoma before? And if they've had a melanoma before, ask them what it looked like, who excised it, how many times it was excised, and any details about the size of the melanoma or if a lymph node biopsy was performed. If you can get the report, that's even better. Then with examination of a patient, it's important to go through all of these. So firstly, to look at the skin phototype, the amount of sun damage they have on their skin all over, whether there's any evidence of other lesions, whether they be benign or malignant, the number of nevi they have all over their skin, whether they have abnormal looking moles, and then if there's a particular lesion, if it has the clinical features of a melanoma and dermatoscopic features of a melanoma. So when I examine patients, I document with what skin type they are. So this is between 1 and, it's a spectrum between 1 and 6, where 1 is very pale or white-skinned patients with red or blonde hair and blue, grey or green eyes. And these patients typically burn very easily and never tan, compared to 6, where we can see that they have black hair, brown eyes, black skin, and they never burn, but they tan. And as we can see there, the cancer risk actually reduces as you go up in the skin phototype. It's also important to document the amount of sun damage these patients have, and it's a good idea to have a look at specific areas, especially on the ears and the lower lip, the back of the hands, and on the face. We know that over time, a lot of farmers typically get skin cancers on the ears and their lower lip because they forget to put sunscreen on those areas. It's also important to count the number of nevi, but sometimes you get patients that look like this and they've got so many moles. So an easier method was studied in this study here. So what they saw was if a woman has more than 11 nevi on the right arm, they were 9 times more likely to have more than 100 nevi. So we know that if you have more than 100 nevi, this increases your risk of developing a melanoma by 7 times. So in other words, if a patient has more than 11 nevi on their right arm, they're more likely to get a melanoma than someone else. All right, so then we look for evidence of other lesions, whether they be benign or malignant. So if we think of the malignant ones, they're either melanomas or non-melanoma skin cancers. If they're melanomas, they're either superficial spreading, nodular, acral, lentiginous, lentigo-maligno, or there are other ones as well. And non-melanoma skin cancers, squamous cell carcinomas, basal cell carcinomas, or something else. So these are just some pictures of the non-melanoma skin cancers up here. So this is a typical BCC, a pearly red papule. With dermoscopy, you can see arborizing telangiectasia. This is keratotic scaly plaque on the dorsum of the hand there, and this is a melanoma. When we think of benign lesions, the 3 main common ones, seborrheic keratoses, benign Neva, and cherryangiomas. Seborrheic keratoses, they have this warty stuck-on appearance. On dermoscopy, you see these milia-like cysts, these little white dots here. You can also see comedo-like openings. They look like little blackheads. You can see fissuring and ridges and sometimes hairpin vessels as well. So here you can see the milia-like cysts, these little white things. You can see some crypts and blackheads there as well. And then up here you can see these hairpin vessels, and here fissuring and ridges. With cherryangiomas, these are benign. A lot of people get these as they get older. Now with benign nevi, the 2 main dermatoscopic features are globular pattern as well as a reticular pattern. Globular looks like these little dots. You can get cobblestone in the whole way through. And reticular pattern is this network-like pattern which is homogeneous the whole way through. This summarizes the different types. So the reticular pattern here, nice homogeneous reticulated pattern the whole way, globular, same. And then this is a combination of the reticular globular. These are all benign lesions, so homogeneous brown the whole way through. And then this is a blue nevus, which you get this blue color, dark steel blue the whole way through. Now, what are the clinical features of a melanoma? Well, clinically, there are a few ways of trying to detect a melanoma. Firstly, we look for the ugly duckling sign, meaning something that just sticks out like that. So you can see that sticks out compared to all the other moles. The other thing is to look at the criteria, A, B, C, D criteria, where we look for asymmetry, irregular border, colour variation, diameter greater than 6 millimeters, and if anything's been changing over time. When we measure asymmetry, what we do is we get the lesion and then try to divide it up so we can draw a line vertically and horizontally and see if it's symmetric on both sides. Some people divide it up into 8 and then have a look at the border as well, so to see whether you can draw around the border to see if it's quite regular or not. So that's for A, B, C, D, E, and this is very good for patients as well, so that when they do their own skin checks, they know what to look for. Then we look for the dermatoscopic features of a melanoma, and the benefit of a dermatoscope is that it's non-invasive and you can see the different colours quite well. There are different types of dermatoscopes out there. There's two main ones. There's a Heine Delta 20, which is a non-polarized light, and then a derm light. This is a DL4. They're both reliable and easy to use. The non-polarized light does not penetrate as deeply compared to the polarized light. The polarized light, however, tends to miss milia on the surface, and you can't see blue as well. The polarized, however, this DL4 can be polarized and non-polarized. And both of them you can get attachments so you can connect it to the camera and then take pictures for the medical records. This is an example here, so you can see the milia here, which are more obvious here with the non-polarized compared to with the polarized. And once again, the non-polarized picks up the blue versus the polarized. If you want to read up on this, there's some good papers. There's Dermoscopy in Routine Practice here from 2012, as well as about polarized and non-polarized dermoscopy. So there's a whole lot of algorithms out there on how to pick up melanomas. I think it's important to look at, or at least read up on these ones, and then try to work out which one you want to use in your practice. They've all got a diagnostic accuracy of about 80%, so they're all pretty good. This is just a simple method one. It's called a two-step procedure. So what you do is you get the lesion and you try to work out, is it melanocytic or non-melanocytic? And if it's melanocytic, then you work out, is it benign or a melanoma? So the step one is you look for pigment network, pseudo-network, aggregated globules, branch streaks, or parallel pattern. If it's all there, then it's a melanocytic lesion. If it has this homogeneous blue throughout it, then it's a blue nevus. If it has those features of a seborrheic keratoses, then it's a seborrheic keratoses. Then you look for, is it an hemangioma or a BCC? And if you're not sure, just call it a melanocytic lesion. Then step two is this 3-point checklist where you look for asymmetry, atypical network, or blue-white structures. And if the lesion fulfills more than 2 criteria, then you biopsy it. The other one is a 7-point checklist where they attribute points to the actual criteria, and if the score is greater than 3, then you biopsy it. So in general, these are the features that we look for on dermoscopy when we diagnose a melanoma. So we look for an atypical pigment network, irregular dots and globules, streaks, irregular pigmentation, regression structures, a blue-white veil, as well as an abnormal vascular pattern. So in this lesion here, we can see that this is very typical here. This has a nice reticulated pattern down the bottom here, but then when you look up here, you can see the blue-white veil, you can see a bit of irregular streaking, irregular pigmentation. The pigment network is abnormal there. Now, blue-white structures, this one's the benign lesion, so blue nevus, the steel blue the whole way through. But then when we look at the melanoma, you can see that it's got this white, blue-white veil. This is all evidence of regression as well. Now, the question is, well, how do we manage a lesion which is suspicious for a melanoma? So from the case, we know that the lesion looked like this. And the question was, should we biopsy it? Or if we do, what's the correct method of biopsying? Well, the guidelines, which this is a very good website to go to, the guidelines actually says that if we suspect a melanoma, the best thing to do is an elliptical excision to the upper subcutis with a 2mm margin with primary closure. So to avoid a flap and graft, but just primary closure like this. Now, if we think that it's going to be just a superficial lesion, then a deep shave biopsy where we get the entire lesion is appropriate. Partial biopsies, however, are not recommended because you actually just take a sample of it. So for example here, if we took a biopsy from this blue area, it might be reported as a benign nevus and we'll be falsely reassured that the mole is normal. But then if we took a biopsy from this red area, it would come back as a melanoma. So we know that punch biopsies are associated with a false negative rate of about 24%. So what do we do when the histology report confirms a melanoma? Well, firstly, when we get the report, there'll be a whole lot of information here: Breslow ulceration, mitosis, regression, and sometimes this can all be confusing. The main thing to think is that these are all indicators of poor prognosis. So with our patient, we saw that it was the right thigh, and the Breslow thickness was 0.5 millimeters, and it was reported as Clark level 3. Now, in 2017, they changed the guidelines. So before, things used to be reported to 0.01 millimeters. So you might see in the old report something, this may have been reported as 0.53, but now they report it to 0.1. So with regards to how to interpret all this, well, if we go back to the layers of the skin, we know there's the epidermis, dermis, and fat layer. The epidermis is split up into the stratum corneum, the granular layer, spinous and basal layer, and then the dermis into the papillary dermis and reticular dermis. When we think of how the melanoma spreads, well, it spreads from the granular layer, which is up here in the epidermis, all the way down. And then when we think of the Clark level, we know that that's the anatomic level of invasion. So Clark level 1 is a melanoma in situ, meaning that it's just in the epidermis here. Clark 2 means that it goes into the papillary dermis. Clark level 3 means it goes into the papillary dermis and completely fills the papillary dermis. 4 means it goes into the reticular dermis. And 5 goes into the fat layer. The problem with the Clark level is a lot of patients, when they see that they've got Clark level 4, they think they've got stage 4 and they misinterpret that. And so they think they've got metastasis. So with our patient, there was a 0.5 millimeter Breslow and the Clark level 3, meaning that it goes into the papillary dermis and completely fills the papillary dermis without going into the reticular dermis. Then the report says that it's a superficial spread in melanoma. Well, there are different types of melanoma. There's the superficial spread in the nodular, the lentigo-maligna, and the acral lentiginous. Superficial spread in melanoma is the most common. It accounts for about 70% of cases, typically on the back of men and the legs of women. The nodular melanoma, pretty much the ones that we're worried about because we know this one can spread very quickly. A lot of times they're amelanotic, so they can be red. They can look like basal cell carcinomas. They can look like pyogenic granulomas as well. Acral lentiginous are the ones typically on the sole or the palm or the fingernails or toenails, and they're more likely to occur in darker skin populations. There's an A, B, C, D, E. In the same way there's asymmetry, border, colour, diameter. There's this one for subungual melanomas where they look for A is for age, so someone between 5th and 7th decade, African Americans, Asians, Native Americans. B is for brown to black and a breadth of greater than 3 millimeters. C is for change. D is for the digit, so typically the thumb or the big toe. E is for extension of the pigmentation onto the proximal nail fold, and F is for any family history or personal history of a dysplastic nevus or melanoma. There's a good article that you can read up on about pigmented lesions on the nail bed. We know that there are a lot of differential diagnoses for pigmentation on the nail. This one's a hematoma, and you can see that because it has that nice reddish brown discoloration there, and there's no extension onto the actual skin up here. Lentigo maligna accounts for about 15% of melanomas, typically in the elderly, and it's very slow grown and occurs on the face. So then there's all these other things that are reported up here. The main thing to know is tumour infiltrating lymphocytes. That just means that the immune system's active. It's recognised there's a melanoma there and it's sending a lot of lymphocytes to try to get rid of the melanoma. Regression, similar. It just means that the immune system's very active, realising there's a melanoma. Mitotic rate means that the melanoma was rapidly progressing. Satellites means that there's a little bit of the melanoma distant to where the primary lesion was. Then we look at the staging and it comes back as T1A. Now this is the staging for primary tumours. So we know that our patient had a 0.5 millimetre melanoma, meaning that it's less than 0.8 millimetres. It was without ulceration, so that fits that it's T1A. So now that we know it's a melanoma, the question is, well, how do we do a wide local excision? Well, if it's 0.5 millimeter Breslow, then the excision will be a 1 centimeter margin. Now, in general, we know that thin melanomas typically don't really spread to the lymph nodes, but there are some patients who are at increase of nodal involvement. This is if they have any of the poor prognostic features of the melanoma. So if they have things such as ulceration, mitotic rate greater than 1, or if they're Clark 4 or 5. So here the question is, well, which patients do we do sentinel lymph node biopsies on? It should be considered for all patients with a melanoma greater than 1 millimeter in thickness, and for patients with a melanoma greater than 0.75 with high-risk pathological features. And with sentinel lymph node biopsies, if that's the melanoma there, that's injected with a dye, the dye goes down and you get that sentinel lymph node and you send that off to pathology. Now, sentinel lymph node biopsies, the key thing is these are done at the same time as a wide local excision, and it's done under general anaesthetic. So it should be done at a specialised centre such as Victoria Melanoma Service or Peter MacCallum Cancer Hospital. So what do I do when the histology report confirms melanoma? If it's melanoma in situ, I do a wide local excision with a 5 to 10 millimetre margin. If it's less than 1 millimetre with no ulceration or negative prognostic markers, then I do a wide local excision with a 10 millimetre margin. If it's between 0.8 and 1 with ulceration or elevated mitosis or any of those negative prognostic features, then I'll refer for a wide local excision and discussion about a sentinel lymph node biopsy. And if it's greater than 1 millimetre, I automatically refer them for a wide local excision and a discussion about sentinel lymph node biopsy. Okay. Now, what do I do if it returns as dysplastic nevus? Because we know that if it's a benign nevus, we're just going to leave it alone. If it's a melanoma, we're going to excise it. But what if it ends up being a dysplastic nevus? Well, they did a survey of Australian dermatologists, and there was a lot of variation in how they would treat these lesions. In a mildly dysplastic nevus, 49% would actually re-excise it. Then when it was upgraded to a moderately dysplastic one, 81% would re-excise. And then when it was reported as severely dysplastic and involving the margin, 62% would just excise it narrowly, but 37% would actually treat it like a melanoma in situ with a 5 millimetre margin. So there was this study here where they looked at patients who've had a lesion which was biopsied, and it was reported as a moderately dysplastic nevus, but had positive histological margin, so it was incompletely excised. What they found was no one actually developed a melanoma at that site. So that's reassuring. But then 100 patients developed a melanoma at another site. So their conclusion was that if you've got a dysplastic nevus or multiple dysplastic nevi, you're at higher risk of developing melanomas later in life, which we already know. So what do I do if it returns as a dysplastic nevus? Well, if it's a mildly dysplastic nevus, I generally don't re-excise it. If it's a moderately dysplastic, if it's totally excised, there's no need for further excision. If it's incompletely excised histologically, meaning that it's still there at the margins, but clinically I can't see any pigment left, then I don't re-excise it. If there is pigment remaining, then I'll re-excise it. And if it's a severely dysplastic nevus, I treat it like a melanoma in situ with a 5 millimetre margin. So how do we manage patients who've had a melanoma before? Well, firstly, it's important to find out as much information as possible about that previous melanoma and taking a good history, including a family history. It's important for patients to practice strict sun protection, wearing SPF 50 plus sunscreen, a big broad-brimmed hat and long-sleeve clothes. They can go onto this website, or they can download the SunSmart app, which is really good because they can read up about skin cancers. They can also read up about UV and how it's affecting them. The consensus is that patients should be taught how to examine themselves, and they should be educated on what to look for, because we know that in Australia it's generally patients, not doctors, who detect 75% of their recurrences. It's important for high-risk patients to have thorough history and examination, and what we look for is any systemic symptoms such as pain, fatigue, weight loss, nausea, vomiting, anything like that, so that we investigate. And if you notice a lump anywhere on their body, especially around the side of the primary melanoma or between the primary melanoma and lymph nodes, then that should be investigated as well. This is just some information which you can give patients to educate them on what to look for. The other thing we do is we monitor with photos, and there's different ways of doing that. So one way is they can go to MoleMap and get photos all over. The other thing is for patients to do photos themselves. So with their with the camera on their phone, they can take pictures of the different parts of their body and then upload it onto their computer. Then every 3 to 4 months, they can get the pictures up and have a look themselves to see if anything's changed. For example, here, this person detected themselves that this spot here had increased over time compared to all the other moles around them, so they picked up that melanoma. There's this Vectra machine, which is a 3D imaging. There's only a few places in Australia that have it. And what it does is it takes all the moles off the patient and lines them up like this, so that when the doctor comes along, they can have a look to see which one actually looks abnormal. The benefit of it is 12 months later, you do it again, and then it compares the first lot of photos to the second lot, so that you can see if there's any change between the first one and the second one. It's really important to have ongoing skin checks. So unfortunately, we don't have a fixed guideline on the frequency of monitoring. Different hospitals and melanoma institutes will have their different guidelines on how often patients should be monitored. Typically, it's every 6 to 12 months for thin melanomas and 3 to 4 months for intermediate or thick melanomas or patients who've had lymph node involvement. It's really important for patients to be aware, though, that if they are worried about any particular lesion or they think that anything's changed, that they should come back earlier. Ultrasound as well as imaging of lymph nodes might be required if they've had a thick melanoma or if they've got lymph node involvement. At the moment, nicotinamide, 500 milligrams twice a day, is indicated if patients have had non-melanoma skin cancers before, but there's no evidence at this stage that there's any benefit in melanomas. If you want to discuss the prognosis with patients, this is a good website where you just put in all the features of that melanoma and it tells you what their prognosis is. In general, we know the 5-year survival will actually reduce with the depth of the Breslow. So in situ, the 5-year survival is about 95 to 100% compared to 50% if it's greater than 4 millimeters. This is a good website by the Melanoma Institute where they have talks on there, and all you do is you just sign up and then you can learn about dermoscopy, how to diagnose and stage melanomas, all about the adjuvant therapy as well as emerging therapies as well. And then this is a good website for patients, so once again by the Melanoma Institute, where they can get information booklets about their melanoma and how to look for a new melanoma. Okay, that's it. Any questions?
How many years should the patients followed up after they had a melanoma? Because I come across quite a few who I see for the first time or so. For how many years should patients be followed up after they had a melanoma?
Yeah, that's a good question. It really depends on what type of melanoma they had and how many melanomas they've had in their other risk factors. So in general, if they've just had one melanoma, I would follow them up for at least 5 years, right? Regularly. But then, once again, that really depends on the type.
That's not seem to do it.
Sorry?
I come across quite a few who you see for the first time and they're never followed up, or they're followed up for a year or two and then they get lost in the system.
Yeah. But they should be having ongoing skin checks there.
Don't the children get melanomas, and if so, at what ages would you suspect?
So we'll just wait for the microphone.
Children.
Do the children get melanomas as well? If so, at what age would you suspect?
Yeah, good question. So
Thanks.
Children can get melanomas. They're, once again, as a child grows, they're more likely to get some moles that change over time, which is normal for them. The issue with children and melanomas is that there's some atypical moles that grow out of proportion. So as the child is growing, we expect some of their moles to just be growing with them. If you see anything that grows out of proportion, so it's growing a lot quicker, if it looks, same thing as before, if it looks asymmetric or irregular colours in there, then it should be biopsied. It can happen at any age. So there's melanomas being reported in very young children, as well as teenagers. So you'd have to put everything together as well, like their risk factors, whether they've got a family history of it. If they've got lots of moles, then they're more likely to get it as well.
You mentioned your two favourite brands of dermoscope. What about the Welsh Allen diagnostic sets with the screw-on oroscope, ophthalmoscope and dermoscopy head?
Yeah, that's fine.
And what's the role of dermoscopy in non-pigmented skin lesions?
So dermoscopy is important for all of those. So for things like basal cell carcinomas, amelanotic melanomas, squamous cell carcinomas, we use dermoscopy for that as well. And there are different types of dermatoscopes. These are just the two that are listed there.
Do those clinics that you mentioned in Melbourne, do they accept referrals from GPs or just from dermatologists for these melanomas?
No, they accept referrals from GPs. Victoria Melanoma Service definitely does. Pretty sure Peter McCallum would, but I know Victoria Melanoma Service definitely does. The benefit of those places, especially Victoria Melanoma Service, is the patient goes in there and they're very thorough. So they have a look all over the skin again. Doesn't matter who referred them in. They'll have a look all over. They'll have a second opinion on the histology report, and then they have a multidisciplinary team meeting where they'll have the pathologist there, a radiologist, med-onc, radiation oncologist, dermatologist, and surgeon all present, and then they make a decision on what the treatment's going to be and what follow-up the patient needs. So they generally don't follow up the patients on an ongoing basis, but they'll say they need to see whoever for skin checks every 6 months or 12 months, and they need this type of imaging every 4 months or so that you have a good idea of what needs to be done.
Just with people who have had a melanoma or are at high risk of melanoma with fair skin, often they're told to stay out of the sun. Do you recommend vitamin D for them? And also, is there any evidence that vitamin D has any preventative effect once they have had a melanoma?
Yeah, good question, because there was some research at Royal Melbourne where they were looking at vitamin D levels and melanoma, and they thought that if you had low vitamin D, then you're more likely to have a worse melanoma. But the issue with that is they should definitely be staying out of the sun, and vitamin D supplements are key for that.
Is there any benefit of doing any pathology testing in people who have had melanoma to detect whether there's any likelihood of recurrence or anything like that?
Pathology like blood tests?
Blood tests, yes.
At the moment, there isn't. They're doing a lot of investigations and studies trying to look for a good blood test. So in other words, if a patient's had a melanoma before, there should be, hopefully in the next few years, a blood test or so where you can detect whether the patient's at high risk or low risk of developing recurrence or a new melanoma, and then that will determine kind of how often you do skin checks or whether they need ongoing imaging or photography, but not at the moment.
I'm just wondering whether locally in Geelong there's any surgeons that or ways that a person doesn't need to go to Melbourne to pursue the later stages. And secondly, people that can't look, I'm wondering about the cost for a patient that can't afford treatment. Is there any, do you have any, can you tell us?
Yeah, okay. Yeah, so it doesn't cost anything. The Victoria Melanoma Service and Peter Mac, it's all public. With regards to here in Geelong, there are people who do it. Geelong Hospital, they do it. The reason why I personally don't send there is because I think it's good to have that multidisciplinary team approach where, if I have a patient who's got lots of nevi, there's always a chance that I've missed a second melanoma somewhere, so I'd prefer to get them checked again by someone else independently as well.
And just back to the pathology tests, as you know, the media love whipping up things years before they become of practical use to us. But there was a recent, just this week, I think, on one of the 7:30 reports suggesting there was some antibody screening test for people who were at risk of developing melanoma. Is there anything that's obviously to the cutting edge of research? Is there anything you can add to that?
I don't know about, I didn't watch that episode, but I just went recently last month to a melanoma conference in America, and they were mentioning that new blood test, which hopefully will come out in the next 2 years, but that they were the ones who were doing all that research, so I don't know about what that new one is. There's no evidence at this stage that vaccines and things like that would help. But hopefully, in the next 5 years, there might be something out there.
Along the same lines, has the 5-year survivability of melanoma changed much with new drug therapy?
Yeah, so if they do develop metastasis, that's when they start getting the checkpoint inhibitors as well as the targeted therapies, and that has helped. But with just primary melanomas, there hasn't been any change there. Good.